welcome to everyone who's joining and everybody who is going to listen in future online. And hopefully it's going to be a useful resource. I'm going to try and avoid sort of a balance between explaining the technical terms and also, just imparting the information and talking through some of the terminology that you may hear or have heard already in the clinics, either with me or one of my colleagues or Professor Sinead Murphy, or any of us working in the care of amyloidosis. Obviously, as you've heard, open to questions. So don't hesitate if there's something that you're either worried about or concerned about, or just want further explained at the end of the talk. So today, just to talk about, I am going to focus on what we call ATTR. And one of my goals today is sort of explain this terminology a little bit so it becomes, less scary, less concerning. Let's start with the word amyloid. What does amyloid mean? Amyloid is a general term for protein. And amyloidosis means there's a disorder in an organ in the body where too much protein is accumulated. So it's in an organ where it shouldn't be. And that's obviously going to cause problems. And in amyloidosis, there are pieces of these proteins, or amyloid fibrils, as we say, in terms of the medical term, which are accumulating. Obviously, if we talk about cardiac or heart amyloid, we're talking about these pieces of protein accumulating in the heart. But it's not just the heart. Depending on the type of amyloid, they can also accumulate very commonly in the peripheral nerves in the body, in the what we call the autonomic nervous system. They're the nerves like the vagus nerve, the sympathetic nervous system that govern heart rate, blood pressure, our bowels, and also, depending on the type of amyloid, they can also involve the gut and the kidneys. There are two main types of heart amyloidosis, so too much protein in the heart. Two main types of that, and the two main types are AL and ATTR. The A stands for amyloid, so it's just what the other letters stand for. AL is a light chain amyloid. So really what you just need to remember here is it's a form of amyloidosis where the protein that's causing the problem and that's, going where it shouldn't, is based from an overgrowth of blood cells, of a particular type of blood cells, the blood cells that produce antibodies, actually. And part of those antibodies are overproduced, and they break down, they become the protein, the amyloid fibril that deposits in the organs. AL amyloid has a specific, very specific treatment, often usually co-managed by or mainly managed by the hematology team, but we cardiologists also, and often kidney doctors, follow those patients. We're going to focus today predominantly on TTR amyloid. And in TTR amyloid, or TTR heart amyloid, the protein is TTR, or transthyretin. And this is a normal protein. We all have it. It's normal. It's not abnormal. It's not an overproduction or an overgrowth of something. It's a normal protein that's made in the liver and that has a couple of main jobs to do. One of them is transporting thyroxine, which is the thyroid hormone. Another one is transporting vitamin A. So important jobs to do. When it comes out of the liver, it should stay nice and tightly packed as a tetramer. So like the top of a milk carton that has the 4 pieces, that's how the protein should be in its normal state. But in the case of TTR amyloid, it breaks down for whatever reason, either because it's genetically programmed to do it, or perhaps something to do with aging. And it breaks down into monomers. Monomers just means one fibril instead of 4. And it's these monomers that become the amyloid protein in the case of TTR, where they deposit where they shouldn't be. And in the case of TTR amyloid, it typically doesn't involve the kidney directly. It usually involves the heart and usually the peripheral nerves. And again, numbness and tingling in the hands and feet may involve the autonomic nervous system, where we think about things like constipation, diarrhea, very low, low blood pressure, or difficult to control high and low blood pressure. So the two types, again, of TTR are the hereditary type, the genetic type, or the type that we're not quite sure, but we know it's probably associated with aging, or wild type. So just a note, again, there may be some people on this call from Northwest Donegal, Weedore, in and around, or have descendants from there or migrated from there. And in Ireland, there are a number of different, there are over 100 different types of hereditary amyloid, like so different, 100 different mutations. But obviously in Ireland, the most relevant to us, not the only, but the most relevant to us is T60A. And that's the genetic type that is based, that does have that heritage in Northwest Donegal, based on that paper by Mary Riley. And it involves the heart, it involves the nerves, and probably more frequently than we used to think, it does also involve the gut. So many of you, some of you on this call may have been at this wonderful conference nearly 2 years ago now, where Mary Riley, shown here, who wrote that paper as a medical student that really first described hereditary amyloid and did a lot of the initial work, came together alongside Julian Gilmore. This is a world expert that leads many of the trials, and ourselves, Professor Sinead Murphy, who works with me in the neurology side of this, in terms of doing the neurology testing and treatments, and then Mark Coyne, I think, who has done a great work as well, getting things off the ground. So just a phenomenal get together then. So just wanted to place things in context of, sort of where we've been with cardiac amyloidosis, and where are we going. And it's really, really exciting. There's a lot of things that have happened in the last couple of years after almost 100 years of nothing happening. It was first described 150 years ago. In nearly 1950, they found it for the first time in an autopsy specimen, or described heart amyloid. And it took many, many years before they looked at specific treatments for the hereditary type. Initially, it used to be a liver transplant, right? So the genetic abnormal TTR, it was thought that, look, if we do a liver transplant, then is that going to be the best treatment? But that had obvious issues and problems. And nearly 20 years ago, a team in LA and Scripps, or in San Diego, found for the first time that you could actually stabilize the TTR. You could stop it breaking down from the 4 to the 1s. And this was the precursor of tafamidis, which some people might be aware of, or already taking. That's the once daily pill for cardiac TTR amyloidosis. There are other treatments that came along, particularly patisiran. Again, that is a treatment that we have available in Ireland, and actually inotersen as well. And these are called silencers. I'm going to kind of explain generally how these work later on in the talk. So one of the questions that I get asked is, we're only just hearing about this in the last couple of years. Is this a new thing? Where has it come from? Or has it been hiding in plain sight all along? And it's probably the latter, that it has been hiding in plain sight all along. We now have a way to diagnose it that's easier. So it used to be that we'd have to do heart biopsies in everybody. And heart biopsy, again, there may be people who've had it listening to this. We do them. It's fine. It's almost always uncomplicated, but it can come with the risk of complication. It is an invasive procedure. You have to come off your blood thinner. There are different things, attached to it, and it can be difficult to get access because you have to come into the hospital, etc. So it used to be that we had to do that. Now we have a scan way to diagnose it, which I'll go through in a little bit. We're more aware of it, and we're mainly more aware of it, and we're looking for it more because we can actually treat it now. I'm old enough to remember when we sort of looked at echoes and ultrasounds of the heart, and we said, yeah, they probably have that amyloid thing, 10, 15 years ago, but we didn't really have any treatments beyond, treat the heart manifestations, but we weren't able to treat the amyloid itself. So it was sort of less important to really put someone through, diagnosing it and getting the biopsy when we couldn't really treat it. Whereas now it's a whole different era. Is there a true increased prevalence of the wild type? You'll see here the wild type is the one in blue, and it's really shot up in terms of numbers of cases. Potentially, as people are living longer, which is a great thing, getting older, then this is probably something that maybe we are seeing more with that. So moving into the body of the talk, again, some of that is maybe slightly technical, but I think just to explain, some of the basics and where we are medically, we're going to go through how it affects the heart, how you might kind of come to be diagnosed with it, how do we diagnose it, how do we treat it, and what happens at the heart clinic or the amyloid clinic. So how does it affect the heart? There are 3 main buckets of sort of effects that we think about with TTR, transthyretin cardiac amyloid. The first is what we call cardiomyopathy. And these are kind of general terms. Cardiomyopathy means there is a heart muscle disorder. And there are a whole variety of conditions that cause heart muscle disorders. Heart muscle disorder, whatever causes it, can lead to heart failure. Terrible term. We'll explain that in a minute. But cardiomyopathy, in the case of amyloid, these amyloid fibrils, so these pieces of protein that are coming from the liver because the TTR is broken down, they're sticking in between the heart muscle cells. The heart muscle cells have plenty to be getting on with, pumping the heart, dealing with the electrical cables that are running down through it without having to deal with sticky protein in the way. Hence, the cardiomyopathy. The next sort of common, or often even before we see the heart muscle or the pump muscle, the pumping chamber of the heart problems, we get atrial arrhythmias. Many people might have heard the term AFib, atrial fibrillation, aflutter, very, very common atrial arrhythmias, very common after the age of 65. Mostly not due to amyloid, but in amyloidosis, many patients, TTR amyloidosis, many will have AFib. So what is AFib? It's an irregular heartbeat, usually fast, although it can be slow, particularly in amyloid. And it's because the proteins, the TTR fibrils, they don't just impact on the muscle chamber, which is the bottom chamber of the heart, they also impact on that top chamber of the heart as well. This is the pumping chamber, and the top chambers of the atria up here. And that's the chambers that control what we call sinus rhythm. They control the pacemaker of the heart, the regularity of the heartbeat. And in atrial fibrillation, in amyloidosis, the proteins can really cover, and I'll show a picture of that, can really take hold of most of the atrium. So atrial fibrillation becomes very, very common. And then thirdly, what we call conduction system disease, and that's a tendency to slow heart rate or slow heartbeat. And again, if you can imagine the amyloid fibrils down into the muscle of the heart, they're not just going to affect the pump or the stiffness of the heart, but the electrical cables are going down from the top chamber to the bottom chamber saying, right, beat 70, 80 beats per minute. Okay, you're exercising, your heart rate needs to go up. But that's when they're uninterrupted. But again, if the amyloid fibrils are in the way, you can get prone to conduction system disease. And this is where we're doing a lot of Holter monitors. We're looking at ECGs in the clinics, and that's because of both of these two things. So I just wanted to say, again, people who've heard me talk before, heard us talk at the Irish Heart Foundation about heart failure, know that we don't want to continue with this term. We're sort of, we kind of don't really have a choice right now because we're trying to get awareness of heart failure in the first place. And if we change the name all of a sudden, but many parts of the world have stopped using that term heart failure. And if I was in the States, I wouldn't call myself a heart failure doctor. I'd call myself a heart function doctor. But still, in this part of the world, we're still sort of building up that awareness before we can change over. So amyloid and the heart pump, it doesn't mean any condition actually that causes heart failure. It doesn't mean that your heart has stopped working by any manner of means. It means that the heart isn't doing its job appropriately enough to meet, or strong enough, or just efficiently enough is a better word there, to meet the demands of your body, and that's heart inefficiency. There is a specific type, typically a specific type of heart failure that we see in amyloid. And again, remember, there could be a combination of types because people with amyloid are typically older. So they may also have had a heart attack, have, that type of heart disease. They may have other problems, diabetes, blood pressure, things that cause. So there can be a combination, but let's just say in its purest form, those amyloid fibrils that come in, they tend to not weaken the heart. So they don't cause that sort of weak dilated heart that you often see after heart attacks or after alcohol or with other genetic conditions. Instead, it's cause a stiff or a thickened heart almost made of stone. And the problem with the stiff or thicker heart is the heart pumps, but then relaxes. So it's not just the pump phase of the heart that's important. It's also the relax phase. The heart needs to pump and relax, pump and relax. When the heart is stiff, it doesn't relax as well. And the relax is when it pulls the blood down from the top chamber and ready for the next heartbeat. So even though it pumps strong the next heartbeat, it doesn't have the same amount of blood in it. So it's the same thing. The body isn't sensing the amount of blood that it should because the heart is stiff. So that's kind of the classic. And we use a term for that, and you might see that in the rest of the slides, HFpEF, or heart failure with preserved ejection fraction, meaning it's not the weak dilated heart, it is its own type. There are other causes. It's not just amyloid that causes HFpEF. Blood pressure is a big cause as well, but that's kind of the prototype cause. So we talked a little bit about this, amyloid and say the heart electrics. It can cause atrial fibrillation, the irregular heartbeat. These are the two top chambers here, the atria, the left and right ventricles. Again, if you have AFib for whatever reason, including amyloid, the top chambers, if they're beating irregularly as opposed to regularly, the blood can pool in the different areas, and that can increase your risk of clot and stroke. So you might be on a blood thinner or what we call anticoagulation. That's very common. And amyloid particularly, and the first sign of AFib, you really need to be, we need to be thinning the blood with one of these medications. And of course, it can cause the cardiac conduction disease that we've talked about. This is the septum in the heart between right and left, where those cables are going down, where the amyloid can interrupt. Less commonly, we see, we talk about the top chamber arrhythmias, atrial, ventricular arrhythmias. We really don't like to see these. These are more life-threatening potentially than the top chamber rhythms. They're less common in amyloid than other heart conditions. And if we do see them in amyloid, it's often because there's something else. There's a heart attack history or there's something else. But we do have to also be mindful it could happen. So how might you end up coming into the hospital, or not the hospital, into the clinic, or what might your GP see, or how might it be suspected in the first place? And still, the most common way that people come, it's not suspected in the first place, in that the amyloid, as I said, hides often in plain sight, because heart failure is common, because atrial fibrillation is common, because peripheral neuropathy is common, and your nerve problems, and nothing is too unusual. And it takes someone to think about it and say, well, hang on a second. Yes, they're in their 70s with atrial fibrillation, but they've also had, they also have peripheral neuropathy. They also have quite a stiff heart. Could it be amyloid? So it takes a little bit of coming together, but that's improving. And we know that, if we take an all-comer group of people with this preserved stiff heart failure, that at least 1 in 10 of them probably have amyloid. And we used to think that in the past. People who have aortic stenosis, that's a very common heart valve disease. Again, it's related to aging. The heart valve calcifies over time, the main heart valve. Again, nearly 1 in 10 of these might have amyloid as well. So we have to kind of we have to think of it. That's on us, not on you as patients and potential patients. It is on us. It's on everybody, though, across the health spectrum to think of it. We did a study in the Matter where we looked at, okay, well, we see a lot of patients with heart failure and a lot of patients, on our wards with this HFpEF, the heart failure with stiff heart, preserved ejection fraction. How many of them could have amyloid? And that's, without us kind of looking too much into things and looking for the amyloid, just all comers. We did some amyloid testing, which I'll talk about, but we found 8% of 86 patients had amyloid, and it hadn't been, found, it hadn't been, considered. Not, I don't know if it had been considered, but certainly by the time we got them, we were looked at these patients, it hadn't been thought about. And so we do know wild type can happen in men or women, but it probably is more common in men if they're particularly of older age. And then some things based on their echocardiograms and on their blood tests can also show us. So just to go back again, we talked a bit about heart inefficiency symptoms, heart failure symptoms. So again, people might think, what does she mean when we're talking about heart failure symptoms? We know the symptoms from an irregular heartbeat can either be no symptoms or can be palpitations or feeling breathlessness. With heart failure, the symptoms, again, dyspnea, or breathlessness, swelling in the body, particularly the belly or the legs, cough at nighttime, cough and breathlessness at nighttime. If you're trying to lay down to sleep and you're finding yourself increasing your pillows or having to sit up, or wishing you had one of those hospital beds where the back of the bed goes up, or needing to get out of bed in the middle of the night, open the window, walk around, not related to you're not just getting up to go to the loo, you're actually woken up because you're breathless. That can be a sign of heart failure. So be very kind of in tune to that. And then other things like being quite bloated or being nauseous, vomiting, feeling like, you can't finish a dinner that you would wolf down, that you're just really full easily. They can also be signs of heart failure. So just wanted to kind of come in and say that from general. AFib, as we said, could it be amyloid? It's common. It's very common in TTR amyloid. So we do need to consider it. These are very pretty pictures here in black. This is kind of a special imaging scan map of the atria. These are the top chambers. The pink areas are normal without amyloid, and this is the whole chamber. So just to show you, a lot of this so the areas that are not pink, purple, are all that amyloid protein. So it really does, when it gets hold, takes up a lot of that atrial chamber. So we tend, when we do see the irregular heartbeat, to manage it. We don't typically too often, unless it's, very early, or very lots of symptoms, we don't typically try to get rid of it with the cardioversions as much, because there's so much of the atria that's involved that, you know, we're like, okay, blood thinner, try and manage it and keep it in sort of a regular rate, an okay rate, not too fast, not too slow, rather than trying to get rid of it. But again, if there's questions about that, there obviously everyone is different. So again, AFib is very common. Who might we think of it? Again, if you're AFib, if you're a male who's in your older years, if you have the stiff heart failure plus the atrial fibrillation, again, they're common. But if they're together, again, that could be a sign of, could this be amyloid? And that's something for us particularly to think about. So CTS there stood for carpal tunnel syndrome. I haven't talked about it so far, but as I said, TTR amyloid affects typically the heart and or wild type, generally maybe not as much in the peripheral nerves. The genetic type really does typically involve the peripheral nervous system, you know, the hands and both feet. Carpal tunnel syndrome is separate, and it's quite common in both types. And actually, we also see carpal tunnel syndrome in AL amyloid. And carpal tunnel syndrome is an orthopedic condition. So, you know, the orthopedic surgeons see this, particularly in people in their 50s, maybe 60s. And here, this is what carpal tunnel syndrome is, a condition where the median nerve in the wrist becomes too tight for whatever reason and causes numbing and tingling, not all in the fingers, but 3.5 fingers on whatever side is involved. It can be both sides as well. But often when the surgeons are releasing it, there's a carpal tunnel syndrome release procedure. Again, people may have had this on this video. They can send a sample of the nerve and see, because sometimes it's the amyloid is there before it ever comes, the TTR amyloid, before it ever comes into the heart and cause the heart manifestations, or even the peripheral nerve. It's in the median nerve. It's causing the carpal tunnel syndrome. And that often happens 5, 7, sometimes 10 years before the syndrome of the TTR amyloid, the heart failure, the AFib becomes. So it's something that we need to think about when we see carpal tunnel syndrome. It's not that we want everyone with carpal tunnel syndrome thinking that they're going to get TTR amyloid, but certainly if I'm seeing somebody with, you know, AFib, with stiff heart, who's had a history of carpal tunnel syndrome, then definitely that case is building up for me that we need to look for amyloid here. And about 14% actually. So what is the prevalence? About in those who have carpal tunnel syndrome, about 14%, maximum 14% may have amyloid, particularly if it's both sides and if they're older, and if there are other risk factors, like it's not coming because of their particular job, or this can be related to occupation. So not just cardiac and neuropathy manifestations, neuro manifestations, but probably we're increasingly being aware of more orthopedic manifestations. So by orthopedic and rheumatological, so that amyloid basically is not just the nerves and the heart, this TTR, but it's probably also affecting the joints. So carpal tunnel syndrome happens many years before. Lumbar spinal stenosis is a big one. So again, spinal stenosis can be common, but for people, lumbar means lower back pain, a tightened spine, having needed a discectomy, or you know, having, you know, already seen an orthopedic surgeon, being told you have spinal stenosis. That is something that we see in TTR amyloid. So again, sort of painting that picture of things that you might end up, you know, you might end up seeing an orthopedic doctor for a couple of things. We think that maybe even some people may have it in their shoulder, leading to the shoulder replacements, hip and knee joint replacements. Obviously, all of these are common, but putting it together with other risk factors, then maybe there is amyloid is a cause of that. So it's just kind of putting the case together. This is something called Popeye sign, which is bilateral biceps tendon rupture. So I think everyone knows their biceps tendon. Again, if that rupture is causing this kind of bulge, hematoma above the elbow, that can be a sign of TTR amyloid. So what tests do we do to diagnose it? We do ECG. So again, as you come to clinic, we'll do an ECG. This is a normal ECG. You take my word for it. It's in regular rhythm. The complexes look quite narrow. What we call, you know, the number of boxes that they're taken up is normal. Very happy with this ECG. when we talk about an ECG that suggests to me that you may have amyloidosis, these QRS complexes can be thicker. That's called a bundle branch block. It can look like someone has had a heart attack even when they haven't. That's called a pseudo infarct pattern. And of course, they can have an irregular heartbeat or atrial fibrillation. An echocardiogram will be done, and it's often one of the main ways that shows us whether or not the amyloid could be in the whether or not this is amyloid, because often it can't diagnose it on its own. But again, if I saw an echo in clinic like this and no other information, I'd say, oh, this is probably amyloid. Let's who is it, or what are the clinical presentation factors, and what do we need to do to diagnose it. So again, you'll be taking my word for it. I'm just showing this to kind of give an example, but this is the left ventricle here on the echo. This is it here as well in another plane, and very, very thickened walls of the left ventricle. These are the heart valves. They're also thickened. They shouldn't be that shiny looking. There's also these chambers. These are the atrial chambers. They're bigger than they should be. There's also a little bit of fluid here, pericardial effusion. And we get this should be read. This is something called strain. If you're coming to my clinic, you'll have heard of us measuring strain. This is what we call the cherry on top pattern of the strain. And it means that for some reason, the tip of the heart here, this is the apex or the tip of the left ventricle, that's here in cross section. That kind of stays pretty okay, and it stays bright red. But the rest, the amyloid involves the rest of the heart, the mid sections and the basal sections. And that often shows us, when I talk about strain, that we're making the diagnosis. But as I said, one of the greatest I suppose, what's the word, advances that we've had is that we're able to diagnose TTR amyloid in most cases, not all, with using a scan. So obviously a scan is a much easier way to diagnose it than doing a biopsy. And this scan, the DPD scan, don't ask me to say that name in full. We just say DPD for short. It's based on a particular type of tracer on a bone scan. And so you get both a kind of an X-ray type picture and a fancier kind of CT type picture. And basically, as I said before, when you inject in, you take your pictures, you put an IV line in, you get a substance injected that's a tracer that is able to show up bone. So it's showing up here in this is black, this is the spine, the shoulders. The heart shouldn't light up with a bone tracer. But the TTR amyloid, when it deposits those fibrils, they have a little bit of a bone substance. Let's call it a sort of a calcium precursor attaches to the fibrils with them. So that's why it takes up the bone tracer. There should never be bone in the heart. And we see here in this very pretty picture, this is the bone here of the spine in yellow. And we see here there's sort of orangey, yellowy, red infiltrate as well in the heart. And that's the sign, that's a positive DPD scan. And so when I'm diagnosing somebody with, how do I know I can use the scan way? And if I've sent you for a scan or had to do a biopsy, or you've already come with one or the other, we need the clinical suspicion, those things I talked about, the stiff heart, the irregular heartbeat, the carpal tunnel syndrome, the family history. Somebody else has my father, I think, a T60A, whatever it is. You have that clinical suspicion. You have some sort of a syndrome. It doesn't need to be heart failure syndrome. Actually, I must change that. Could be AFib. It just could be a clinical suspicion. And then you get to what we call the basic testing, which is the ECG that we show, the echo, that strain, that's GLS. Sometimes we need an MRI, but not always. Usually not, unless the pictures on the echo don't show us much. Although some people have an MRI anyway, and that's how they come to us, which is fine. What you need to do, we always need to outrule the AL type first. We use that with blood tests. And whether or not we can outrule the AL type with the blood tests is what determines, can we do the scan or do we need a biopsy? Because even though the scan that I showed is very good at showing up TTR amyloid, in small number of cases, it could also light up with AL. So mostly no, but in a small number of cases. And if we just do the scan and say, grand, scan is positive, it's TTR, and treat for TTR, we could miss a few, not many, but we could miss a few ALs. And that's just not, we can't do that because AL has such a distinctive treatment that's very, very different. That's chemotherapy type treatments. So we do the blood tests. If those blood tests, you'll see me asking for serum-free light chains in case I need those blood tests to see are those antibodies, parts of the antibodies in the blood. If they're not, there's no suggestion of the AL, we can go on to do the DPD scan. And then the DPD scan, that's just a fancy name for it, but the DPD scan, then if that's positive, that's the diagnosis made. After that, we need to do the genetic test because we need to see, is it the wild type or is it genetic? And typically we do the genetics now that are more available in everybody. Even if we think it's wild type, there's absolutely no link to Donegal or other parts of Europe where there are other mutations, then we typically do the genetics for everybody. So we're getting there. A few brief words on treatment. How do we treat the heart manifestations? And actually, this includes the peripheral nerve as well, and the other manifestations. But as I said, I'm focusing here quite mostly on the heart. So there are kind of what I think about 5 pillars of therapy. Again, just on the terminology there, HTR is just TTR, CM is cardiomyopathy. I probably should have said CA, cardiac amyloidosis there to keep it consistent, but basically TTR, cardiac amyloidosis. What are the therapies that we have up to now? So I think of 5 buckets of therapies. The first bucket I think of is what are the actual disease modifying therapies? What are the treatments that can change things we're not just managing the kind of consequences, but we're actually trying to maybe stop the amyloid in its tracks. Can we reverse it? What can we do? And we don't think that we can yet reverse it. But again, there are lots of studies ongoing, lots of new agents. And that's a sort of a source of ongoing study. But the treatments that we have right now certainly have shown ability to stop it in its tracks, for want of a more technical term. So for wild type, we have one main treatment, which is tafamidis, which is an oral tablet, which is a stabilizer. So and I'll actually show that in a bit more detail coming up. There is a newer agent though coming called acoramidis, and we're excited about this, not necessarily because it's any better. We don't know if it's any better. They haven't been tested head to head, but it has been tested with placebo, and several of our Matter patients have been enrolled in that clinical trial. So very, very thankful to them and all the patients involved, because it really moves the field forward. But what's really useful is these are really expensive therapies. We're lucky in Ireland that we have a managed medicines program. Tafamidis is approved. So if we sort of jump through all the hoops and have everything appropriately for the diagnosis, then we can get access. But it's hoped that, again, if we have another agent, it doesn't need to be better. Even if it's as good, then that'll bring down cost and increase access. For hereditary TTR amyloid, if you have the peripheral neuropathy confirmed or autonomic neuropathy, and your nerve-related disease, then you're entitled, or you're eligible for patisiran. Patisiran is the silencer; it acts earlier, which we'll show. There's also another type of silencer called inotersen. We do have available if somebody, but generally there's a lot more monitoring with it. So we typically have it available if somebody has, say, an allergy to patisiran, but it's not widely used in Ireland. Now, there are some patients, you may be a hereditary patient looking at this and saying, a genetic patient and T68 and saying, well, I'm not on patisiran. It is as yet only licensed in that we can only prescribe it for patients who have the neuropathy. So I have many patients with the genetic type, the hereditary type, who are on tafamidis, and we keep an eye out to see if there's any developing neuropathy, which would make them eligible for patisiran. In the future, could we have both agents together? That would be really exciting to silence and stabilize the disease. But let's see. The second bucket is sort of the heart inefficiency treatment, the congestion management. Patients, if you've started to have some fluid issues, you'll be on a loop diuretic, that's furosemide or Buronex, bumetanide. You may be on spironolactone, aldactone, which is very good as well. It's a weaker diuretic, but it's very good for the heart. There are newer medicines that other people with heart failure get, like Farxiga, Jardiance, or dapagliflozin, which we're using more and more in our amyloid patients as well. They seem to be quite useful to kind of control that heart inefficiency syndrome. The third bucket are what we call the device therapies. So you may have had a pacemaker, or you may be waiting for a pacemaker, or we may have said, again, if you remember that conduction disease, the slow heartbeat, some patients, because the amyloid fibrils have interrupted that conduction tissue, we do have to implant a pacemaker. An ICD is a defibrillator. Some people might have it because they also have had a heart attack or other types of weak heart disease. It's not common for patients with amyloid unless they have another reason. So if they do need what we call a device to regulate heart rate, it's typically the pacemaker. And that the fourth bucket is treating the atrial fibrillation or the atrial flutter. If there's a lot of fast heartbeats, how are we going to treat that? Traditionally, if we have AFib without amyloid, then we often use a lot of beta blocker. We can't use too much beta blocker for amyloid because of the tendency to slow heart rate. So if you come to see me often for the first time, what I'm doing is reducing beta blocker doses, cutting it down, sometimes stopping it, because even though it's useful medicine, they're not dangerous medicines. We use them all the time. But again, it's just tailoring the right medicine to the right condition, the right patient, because it may be that they may make the heart too slow. Now, often we try maybe and leave a small amount on and do the regular Holter monitors where we look to see, well, what's the average heart rate? Is it going too fast? Is it going too slow? Is this dose okay? The fifth bucket, for good reason, we don't see too often, very, very rarely. I think transplant in the States, we saw a couple of people maybe who had wild type in their 60s. Usually we don't think about transplant after sort of late 60s on, in terms of all the complications and all of that. It's a big operation. But potentially, and I'm talking about heart transplant here, but again, ideally, we won't need to think about it at all, even if you are young enough to consider it, because we'll have had started the treatments so early, and people won't progress. So again, just briefly mentioning the disease modifying treatments. This is just a schematic of how you get from the TTR in the liver into the peripheral neuropathy, the fibrils that form the peripheral neuropathy, and the stiff heart disease, or the restrictive cardiomyopathy, or the heart failure with preserved ejection fraction. This is the TTR coming out of the liver as a tetramer. It in the case of TTR amyloid, breaks down into these monomers, and these monomers become the amyloid fibrils that cause all the bother. And the two main types of treatments are the stabilizers and the silencers. The silencers, like patisiran, just stop the TTR in the first place. Stop it at source. Most of it, now remember, I didn't read, about 85% of TTR, 85% of it is in the liver. There's also, though, some in the eye. But of the liver, the patisiran works and the inotersen at the level of the liver to block TTR production there. The tafamidis works, and the newer agent, and diflusanil, I didn't really mention that. Let's see if there's questions on it, but that's a sort of it's not a newer disease modifying treatment. It's a painkiller that's been around for years and years. And before we had anything at all, it was realized that it probably had some stabilizer properties. And so in some patients at the start we're on diflusanil, and sometimes patients with patisiran we may continue diflusanil as well, just to try and get both on board. It's not it's not on a special access program, but not very often. But the stabilizers like tafamidis and the newer drug, they stop breaking down, they kind of lock it in place, and try and close those gates, and prevent TTR escaping at the sides. So finally, what might happen at the amyloid clinic? We'll be asking about things like heart inefficiency symptoms. We'll be asking about, collapse or fainting because of maybe risk of slow heart rate, palpitations, fast heart rate. We will be asking about neuropathy type symptoms. Have you numbness or tingling in the hands or feet? Or autonomic symptoms. That's more about the autonomic nervous system controls bowel, bladder, erectile dysfunction. Early erectile dysfunction could be, an initial sign. So we'll be asking about those, generally, obviously, other major health issues, and medications. Have we started medications? How are you feeling on them? What are the tolerability? We'll be measuring blood pressure, your heart rate and rhythm, your weight in terms of potential fluid overload. We'll be doing an exam where look at your neck veins. That helps me to determine how much fluid you may have, feeling your pulse, is it regular, listening to your heart and lungs, looking at your feet, your abdomen. We'll also be potentially sending blood tests, particularly the heart failure blood test, the NT-proBNP, which is very useful, and the kidney function. And there is a staging system that we can help to say, well, what stage is somebody at based on their kidney function and their NT-proBNP. So it's kind of handy to have those. I often try and get the GP to measure those maybe before I'm seeing somebody. So I'm able to say, well, look, great. There's 3 stages. Stage 1 is the best. They're still stage 1, or they haven't progressed yet, or maybe they are progressing. There's something else we need to do. On the tafamidis, we need to measure liver function. On patisiran, there are other bloods we check periodically. We do a 12-lead ECG at every clinic. We also every so often, periodically at the start, and then maybe once a year, check in on the echocardiogram. How thick is the heart muscle? Have there been, hopefully, we don't typically see it go back to normal or regress, but we want to make sure it's not progressing. And then we'll also do that 24-hour Holter monitor every 6 to 12 months. And based on that, then we kind of summarize things, answer any questions, follow-up plans. We also, if you're not from Dublin, obviously we're going to try and get some of the tests locally and try and work with your local heart failure clinic. And that's what I mean. At your local heart failure clinic, they can do a lot of things that are very useful to sort of kind of feed into us as a spoken hub model in terms of, how are you feeling? What's your weight like? Checking the BNP and the kidney blood test, doing the ECG, echo. A lot of these things, the diuretic adjustment, the water tablet adjustment can be done locally. I can't stress this enough. I'm obsessed with blood pressure. We all need to be obsessed with blood pressure and getting our blood pressure controlled, because amyloid is a condition, as I said, that causes a stiffer heart, can cause stiffer heart function. Then so is blood pressure, and it's obviously the common reason. And I see a lot of people who maybe are on a blood pressure tablet, but it's not really controlled. They're only on a low dose of one tablet. There's no point not having your blood pressure perfectly controlled. So definitely make sure you have your 24 blood pressure monitors from your GP. Make sure that your blood pressure is within the range that it should be at, and don't kind of half treat it. We need to look for other common things in this age group. Are there reasons for a stent? Or is there angina? More sort of kind of common coronary artery disease. We always want to minimize alcohol with any heart failure and any heart condition. Avoid smoking, and definitely exercise is so important. Staying active, doing both your aerobic, your walking, your steps, your cycling, your swimming, your dancing, as well as your resistance exercise. So just lastly, on the current referral pathway, we don't yet have a national strategy, or people say to me, oh, how can we get referred to you? Again, in a good way, I think hopefully that's less relevant to actually to see me or one of my colleagues in the matter, because there is so much more increased awareness. So if you're coming at this with having heart symptoms, manifestations, the heart failure, the atrial fibrillation, the slow heart rate, then your local, wherever your cardiology referral site is. And thankfully, we now have more and more of the community hubs, the sort of the stepping stone between the GP and the hospital, where people can do, where there's cardiologists working that can do echoes, can do ECGs, and certainly are aware of this condition, and then get referred on if needs be. If you have the more the neuropathy, the autonomic type symptoms I talked about, the peripheral neuropathy, then you're going to go to your local neurological site. Sinead Murphy is sort of the super expert in Tala that we work with. If you have a family history, so T68 Donegal area, you can get referred direct without any symptoms, and say of a younger age, then you're not seeing it. That's too early for an amyloid clinic in a good way. But if you just want to get your genetic testing done, you can refer directly to Crumlin or the Family Heart Screening Clinic in the Mater, if you have a family history and you're looking to see, look, do I have the genetic test? If we've seen, either myself or Professor Murphy or some of our other colleagues, a first-degree relative, so mother, father, brother, sister, with symptomatic disease, and you're of a certain age, typically around about 50 or so, late 40s, 50, then we can do that genetic screening at the Mater. That's sort of just a general. We wrote a working report in 2020, still not funded, which is unfortunate, because really wanted to, there's so much more that we could do, and there's such a need in amyloidosis. And thank you to any of the Donegal AMI group, the wonderful group who've been helping us with this and getting it through in terms of the HSE and the DOL, in terms of patients' questions and representative questions, because we really need it. We really need more of a funded service where we have multidisciplinary teams, where we have, admin support, registry support. We need to look at our outcomes, making sure that we're putting people on the right medications, that we're monitoring it. So there's a lot more to be done in terms of resources. So in summary, TTR amyloid fibrils are protein pieces. In the case of TTR amyloid, they're coming from the transthyretin protein in the liver. They can infiltrate the heart and the peripheral nerves, and cause and the joints in terms of orthopedic manifestations, the median nerve. And in the heart, they can cause heart inefficiency, AFib, slow heartbeats. There are many treatments. You saw those treatment pillars, and ideally the treatment is multidisciplinary. I'll finish there. So thanks very much for listening.